Thank you very much, Ubaid. I'm very happy to be here after two years gap, this meeting. And today I'd like to talk about why we should do CTO PCI. I don't want to focus on indication that much. Wakar mentioned some indications, but I like to talk about why we should involve CTO PCI, because I believe that some of us definitely should do CTO. And if you look at clinical indications for CTO PCI, for example, in open CTO cases, one of the goals is improvement in lifestyle limiting angina or dyspnea. And other thing is some patients is not eligible for CABG operation. They have poor surgical candidate. They might be poor surgical candidate. They might have poor distal targets, and patient choice sometimes important. Some patients definitely don't want to go surgery, as you know, and some patient has low medium syntax score, and also in patients with non-left main or proximal LAD disease, we can do PCI. And if you look prognostic importance of the CTO, yes, CTO was associated with higher mortality, especially in patients with STEMI and younger patients. And complex vascularization multivessel with at least one CTO is also important. If we open the CTO, the mortality rate is less. So, of course, I mean, there are levels of CTO. Level 1 is easy, level 2 is more difficult, and level 3 is complex CTO. We should be aware of this. So, not all CTOs are the same. And currently, most of us will follow this chart. If we have CTO, we ask symptoms. If there is symptoms, and if the heart wall motion is normal, ejection fraction is normal, I think there is indication. We have symptoms, but we have akinesia or dyskinesia in the echo, then it's better to do viability. If we have viable tissue, yes, there is indication. If there is no viable, there is no need to open CTO in that case. If there is no symptoms, but the ejection fraction is normal, we can check ischemic burden. If it's higher than 10%, yes, there is indication there. If the ischemic burden is less than 10% or 8%, we can do medical therapy. If there is no symptoms, and if there is CTO and akinesia, again, we can do viability study. If there is viable tissue, we can open the artery. So I like to share you some cases. I don't see any option rather than open CTO, for example. In this patient's 58 years old male, ischemic burden is 14%. There is some moderate lesion at the proximal LAD, but it's not severe, and circuit looks okay. There is RCA CTO, we have a filling from left system. So, and this patient has symptoms. We can't send this patient to surgery if they do Lima to LAD graft. I don't think Lima is working well because LAD itself is not that much diseased. And this study shows us ischemic burden is important in mortality. And we are like a cutoff value 10% for that. And this is level 1 CTO. Many of interventionalists can open this CTO if they have proper devices like microcatheter and some CTO wires, because it's short and straight vessel. This is level 1, and many interventionalists can open this artery. So I think that for this patient, there is no option other than CTO PCI. And for example, another patient, this is a very young chap, 34 years old guy, class 3 angina, RCA CTO, but the left system is normal, so a very young chap. And you see, it's very long disease, complex. This is level 3, but still, I think we have to do something about this RCA. Especially, you know, this study shows mortality is higher in STEMI patients if they have CTO. So RCA is occluded. If something happened to LAD, this patient might have in much more risk. I'd like to show the result here.
Oradan mı?
Yani hocam sızmış yavaş yavaş.
Long stent, and we had a good result. So I think this is complex case, but still we have to do it. Another case, 58 years old male, class 3 angina. ECG has some changes. Echo is normal. And what do you think about this patient? We have big diagonal, 95% stenosis. LAD is occluded, but very long occlusion. There's a septal collateral here. And how about the other vessel? The circ, RCA is okay in this patient, but the circ also diseased. In here, we have a distal circ lesion is almost subtotal occlusion. We have subtotal occlusion here. So what do you think? Can we send this patient to surgery? I'm not sure if it is if this patient is good candidate, because LAD is very long diseased and there is not that much good graft place. So we did PCI in this patient. We did 2 stent for verification and also some stents. This is absorbable stents, and we had open nice LAD, and also we treat circ here. You see, it's a long circ, not that short, and I don't think this patient has option rather than CTO PCI because he's basically not eligible for CABG operation. Another, I think, scenario could be this one: RCA occluded, and graft is very diseased. This patient had surgery 10 years ago. Very ugly, very diseased graft. I don't think we can do anything this graft, but this is very big RCA, and left system is like that. Circ is okay. Lima is occluded. LAD is occluded, and Lima to LAD is not working well. That's the scenario. So what we do? I think the best option here to do open this RCA. You know, we have a nice retrograde option using this degenerative graft as we did here, and we can open this as retrograde approach, and we have a very huge artery, and this patient needs this artery. So I think we don't have any options rather than open this. And this is, I think, another very important scenario for me, post-CABG patients. Anyway, you know, most of the patients, CABG patients after 10, 15 years later will be our patients, you know, because CABG and CABG operation is not forever. This patient had CABG operation 10 years ago. There is no LAD, there is no circ, and RCA is rudimentary. And this is the point. We have graft to OM, and OM, diagonal fills the OM. So we have one graft in this patient goes to diagonal, and that diagonal fills OM. So this patient sent to us to open this graft, but you know, it's very high risky patient, very thrombotic lesion. There is high risk for no reflow. So how we can approach this patient? What we did here, we did another injection to see the whole story. You see that there is CTO, but subtotal occlusion, OM. So we think that we should first open that OM. You know, if something happened to graft to diagonal, then that OM will help to diagonal. So, and our work will be easier in that case. And we did in that patient. So we have also big circ here, and this is after OM stenting. And after that, we did, of course, graft in the same setting. We put stent, But look, after stenting, we have no flow now because filter fill with the, can I have another 2 minutes, please? Or 1 minute? Is that possible? So filter was filled by thrombus. Imagine that if you don't have any circ flow, it will be trouble. And this is after after filling, very nice. And then in this case, we did also, since we have a huge circ, we also open this patient's circ as well. As you see, we have septus collateral is a really huge circ, and this is after circ intervention in this patient. So we have two big OM and circ after stenting. So this is the last patients for this presentation. This is really the patient's very, again, young, 44 years old, ejection fraction is low. There is viable tissue everywhere, but he had Kebich operation. There is no vessel that much. The left system, you know, Lima right is occluded, circ is occluded, Lima 2 LAD is working, but there is a severe stenosis after anastomosis. This is the situation, and patient has really, he cannot walk even, you know, meters. So we did first left main to diagonal intervention, and also in this patient we use PulseCat as assist device if we have any problem. But in this patient also we think that it's important to open LAD CTO just for, you know, to be secure. If there is something wrong in Lima to LAD, you know, we just open and we just dilate the LAD. We didn't do anything because LAD was occluded. Instant occlusion, so we think that it's not that good to do it. This is after stent through Lima. So Lima looks good now, and this is after 6 months. LAD diagonal, diagonal is good, left main is good, and even now Lima works very well, and the result is good.
Excellent.
Yeah.
Excellent.
Yeah. So we had open RCA and other ways anyway. So what I want to say. Some of us definitely should interest CTO because there are lots of patients, they have no option. So I'd like to share with you the last slide. This is RCA in this patient, and also we open the circ. I'd like to show you this. Anyway, we should start CTO cases, grow a CTO practice, establish a CTO program, and we teach how to do it. This is very important, and especially for young cardiologists, I think this is a very good field, you know, to be trained. And I'd like to invite you to our meeting, CTO Essentials meeting this year in Istanbul. Please join us. It will be a very good meeting, hopefully. Thank you very much.